Thank you so much. So today I'm going to be talking about ambiguous genitalia and some of the ultrasound tips and tricks that we use when we're assessing these patients initially. I have no disclosures for this. So when we have an infant that's born with ambiguous genitalia, um, this isn't necessarily an emergency, except this implies a possible difference of sexual differentiation. And this can really feel like an emergency to a clinical team and to parents. However, it's really important to know that these infants are typically healthy, and from a medical standpoint, they really do not need emergent imaging. Even with congenital adrenal hyperplasia, where these infants need to be identified prior to having a salt wasting crisis, they don't manifest these findings until several days of life. So it gives you time to really think about an imaging approach. And we also need to remember that not every DSD patient is going to be identified at birth as having ambiguous genitalia. We can have XY patients with androgen insensitivity who are going to have typical appearing female genitalia and would not be identified by an abnormal physical exam. However, a lot of families may have had karyotypes or free fetal DNA imaging prior to birth, and they might have they might identify that there's an incongruity between the typical female appearance of the genitals and the known XY genetic material. In these instances, some children with androgen insensitivity might be imaged in the neonatal period. So, our objectives today are that we're going to review the current concepts in embryology of the reproductive system and use the terms that we're kind of currently utilizing to describe DSDs. We're going to describe strategies for initial ultrasounds that we perform for patients with ambiguous genitalia. And then at the end, we're going to review some of the most common DSDs that we see in children. So, really, a lot of this goes back to embryology. And when we think about the embryology here and kind of what happens, it's kind of a good way to think about what we might see in different patients. So, during our sixth week of gestation in embryonic development, there's a bipotent gonad, and it either becomes a testicle or an ovary, which is the process of sex determination. And a really key part of this process is the presence of the SRY gene on the Y chromosome. This is what spurs the development of Sertoli cells in the gonad and creates a testicle out of this bipotential gonad. Historically, embryologists talked about ovarian development as kind of a default pathway of gonadal development that occurs in the absence of the SRY gene. But we now know that there are other genes that are required for ovarian development, so it's not as much of a default pathway as it is a different pathway. So, following sex determination, where we decide if we have a testicle or an ovary, we then have sex differentiation, where the external and the internal genitalia develop masculinized and feminized appearances. So, a key issue here really is the absence or the presence of testicular Sertoli cells. So, if we have testicular Sertoli cells, those cells are going to be producing this anti-Mullerian hormone. The anti-Mullerian hormone is going to lead to a regression of all of the Mullerian structures that we see, including the fallopian tubes, the uterus, and the upper vagina. In the absence of anti-Mullerian hormone on this side of our pathway, the Mullerian structures are going to be preserved, and low androgens are going to allow for that feminized appearance of the external genitalia. And finally, in patients who have normal testicles, Leydig cells are going in the testicle are going to be producing testosterone and supporting production of dihydroxytestosterone, which creates our masculinized genitalia. So, what are some of the things that we want to think about with embryology here? It's really critically important to identifying our ultrasound exam. So, first, you want to see if you can identify something that looks clearly like a Mullerian structures. Let's say you find a really clear neonatal uterus like this that has a nice echogenic endometrial stripe and has kind of the classic endometrial contour with this very small fundus and the larger cervix. Some people talk about this as kind of a spade-shaped uterus. Once you've identified this uterus, this should really imply to you that anti-Mullerian hormone is not present. You're not going to have a testicle with functioning Sertoli cells, The gonad that you have should be either an ovary, maybe a streak gonad, or some sort of dysgenetic ovotestis, but you're not going to see a typical testicle. If no Mullerian structures are present, you should be looking for a testicle as you look on to search for gonads throughout your ultrasound. Another part that is really difficult with DSGs and patients with ambiguous genitalia is figuring out how we're going to use nomenclature and terms both in communication to other physicians and communications to the family. Historically, there were a large number of terms that have been previously utilized, but these were often gender-based. These were often felt to be stigmatizing to patients and very unclear. In 2026, there was a consensus system that was developed for classifying DSDs based on sex chromosomes and karyotype, and this allows for more precise definitions and better descriptions of these definitions that we can use. So, this is our current DSD classification, and there are three main groups of DSDs. First, we have sex chromosome DSDs, where there is an atypical complement of sex chromosomes. These are things like Klinefelter's, where we have XXY, Turner syndrome, where there's just a single X and no Y chromosome, things like a 45X or 46XY types of abnormality or mosaic conditions. So these are sex chromosome DSTs, and typically, if people have had a karyotype, this may have been identified. Patients with a typical complement of XY chromosomes will have 46 XY DSTs, and these are most commonly caused by atypical testicular development or some sort of disorder of androgen synthesis or action. So, are you not able to make your androgens? Are your receptors for your androgens inappropriate? These are all patients who may have 46 XY DSTs. And finally, we have patients who have a typical number of X chromosomes. So XX will have a 46XX DSD caused either by atypical ovarian development or an androgen excess that leads to a masculinized appearance of the external genitals. Interestingly, having estrogen is not necessarily needed for the appropriate development of an XX patient. If you are still more familiar with the historical nomenclature that we've had from before, or if you ever are looking kind of in the literature and you see more of historical nomenclature, this is a chart that you can use as a reference. And it correlates some of these historical terms that have been used along with the more modern classifications of DSTs that we see. So now that we've talked a little bit about the embryology and the nomenclature that underlines DSDs, we're really ready to look at how this presents in practice. So DSDs are actually kind of surprisingly common. We see these in up to 3,000 or 300 to 15, 1 in 300 to 1 in 1,500 births. But that significant genital ambiguity is seen in about 1 in 5,000 births. Um, what are some of the clinical findings that might lead a clinical team to think that there is a possible DSD in an infant? So, first would be a infant who is a bilateral apparent male infant who has bilateral undescended testicles, a bifid scrotum, or hypospadias in the setting of another GU finding. For an apparent female infant, clitoromegaly, a single GU opening on the perineum, or inguinal hernias may prompt an imaging assessment, and typically these are bilateral inguinal hernias in these patients. So, what are some things that we should do when we're thinking about evaluating these patients? The first thing you have to remember is this is not an emergency. Congenital adrenal hyperplasia is really the only life-threatening diagnosis, and this is diagnosed as a laboratory finding marked by elevated 17-hydroxyprogesterone, which will be identified on the newborn screen. Once you're doing this for these patients, you have time to obtain all of the relevant information, including a karyotype if it's available, prenatal imaging if it's available, information from the physical exam or the family history. And you want to remember in these cases that these are team efforts. Many other clinicians from endocrine, urology, genetics, other specialties are all joining and caring for this patient. And you don't really need all the answers. You don't need to give patients answers when you're scanning. And many other people are going to be communicating with the family too. So communication with these families becomes a big issue, and everyone who interacts with the family, including our sonographers, need to think about communication. You really want to be positive. Use terms when you're seeing the baby, like your baby, the child, your infant, without using gendered language. You should try to be descriptive and factual if scanning with the family members present. So if we come in and we start scanning and we're not sure what we're looking for, we can use terms like Mullerian structures and gonad. If we're not sure what we're seeing, if we're not sure how we can describe a structure. And it's important to remember to be really sensitive to the terms in the reports as well and think about the timing of the reports because the patients are going to be getting immediate reports for these. We know that everyone has immediate access to everything in the EMR, and you want to make sure that your reports are not going to provide a surprise to the patients that they may not have heard of before. So before you go and scan one of these patients, you might want to mentally run through kind of an ultrasound checklist, thinking about what you may be encountering. You're going to want to look for the uterus and other Mullerian remnants like a ventricle and identify if they're present or absent. You should expect to find a gonad on the left or right. We should be able to find one on both sides. And they may be the same or different in appearance. You want to think about kind of all of these possibilities. Is it an ovary? Is it a testicle? And we'll talk about how we differentiate those. Is it a streak gonad? Is it something that could be an ovotestis, or are we not seeing anything? The adrenal glands should really be assessed in all of these patients, and you want to determine if they are normal or hyperplastic. And you can identify abnormalities in the kidneys in several of these patients, so you want to assess those quickly just to identify abnormalities. As far as our scanning goes for these patients, high frequency linear transducers are really ideal. The typical anterior sagittal approach right here, kind of through the abdominal wall, uses the bladder as a sonographic window and provides images to the bladder, the uterus, the upper vagina, and the rectum. This is really complicated by the transperineal and the posterior sagittal approaches, which can be used to evaluate the urethra, the lower vagina, and the distal rectum. So let's start by talking about the uterus. The uterus is evaluated with that ultrasound probe in the anterior sagittal position, and it has a very typical neonatal experience from exposure to maternal estrogen levels. We see the thin fundus and the bigger cervix. We talked about that a little bit earlier. As estrogen levels decrease, the uterus develops its prepubertal contour, where it is just very thin throughout with a narrow fundus and a narrow cervix. So here we see our tiny uterus here, like a little banana, narrow fundus, narrow cervix. After puberty, the uterus develops its more classic pear-shaped appearance, the adult appearance that we're typically identifying. And we see that we have this nice wide fundus and the smaller cervix. But at all of these ages, there is one finding that we're seeing here really consistently, and that is the echogenic endometrial stripe that we're seeing in all of these patients. The endometrium is echogenic. We're seeing that at kind of the middle of our uterus. And we can identify, you can use that to help us identify the uterus in cases that are difficult. And importantly, once we've identified that the patient has a uterus, we also know that the patient is also going to have an upper vagina because both of these structures come from Mullerian precursors. But the uterus is not the only Mullerian structure that we can see. We may see other types of Mullerian structures. Children may not have a uterus, but they may have something like a prostatic utricle. In the image on the left of the screen, the bladder is seen anteriorly with a debris-filled utricle identified posteriorly. On the center of the screen and on the right of the screen, these are longitudinal images of the bladders of two different patients with cystic structures seen behind the bladder here, representing utricles as small Mullerian remnants. And if you are unsure what you're looking at, referring to something as a Mullerian remnant is appropriate. If you don't know if it's a uterus, is it a utricle? What is this? And this is a patient who had XY gonadal dysgenesis. And what we saw on their ultrasound is we saw the bladder anteriorly, we see the rectum back here. But then there is this soft tissue that's kind of between the bladder and the rectum. This was a Mullerian remnant, and it was just described as such in the report. We're going to move on to gonads now. So after assessing for Mullerian structures, you can move on to searching for the gonads. One should be present on each side, and they can be similar in appearance. There are four types of gonads that you may encounter. The first one, which will be ovaries, which we can identify because we're going to see small hypoechoic follicles. The follicles can be more prominent in the neonatal time and during puberty, but they can be present throughout life. Testicles should have a pretty homogeneous echotexture with a very distinct echogenic mediastinum that defines the structure. So you'll look for this bright echogenic mediastinum down the center of your testicle. When we see an ovotestis, you may see something that has some little cysts in it that look like follicles, as well as a little echogenic mediastinum. And this is kind of showing both the characteristics of the ovaries and the testicles. And finally, you can have streak gonads, which are these irregular fibrous structures. These can be very small and difficult to identify in ultrasound, but we're going to take a look at some various examples of each of these types of gonads. So these ovaries belong to, in the left upper corner here, we have a neonatal ovary. In the right upper corner here, we have an 11-month-old ovary. In the lower right corner, down here, we have an 8-year-old ovary. And over here, we have a 17-year-old ovary. So ovarian volume, it's important to note that this changes with age. We'll see them being sort of approximately 1 cc at birth, a little bit less than that in young childhood, and approximately 8 to 10 cc's following puberty. But if we look at this, we can see the ovoid shape is very similar. Little cysts can be seen throughout all of these periods of life, and it really has kind of a similar appearance in all of these children. Now, the testicles, we can look at a testicle on the left of the screen that belongs to a neonate, and the one on the right of the screen over here is a testicle that belongs to a 21-year-old. Although the testicular volume in this neonate is about 1 cc and the adult testicular volume is about 15 to 20 cc's, we can see both of these structures have a very similar, homogeneous, just a kind of a bland echotexture to them. And they both are really distinguished by having this echogenic linear mediastinum in the mid portion of the testicle. So when I'm looking for something on these cases and I'm trying to decide, is this a testicle? What could this be? I look for this echogenic mediastinum. When we have patients with an ovotestis, this can be difficult. These ovotestes contain both ovarian and testicular elements, and when you're evaluating a gonad, you really want to look to see are there any types of small cystic structures in this parenchyma that could suggest an ovarian component. This image on the left is a surgically proven ovotestis in a child with XY gonadal dysgenesis. This patient had these little cysts that we're seeing in the gonad right here, as well as this linear echogenic area here, which was an echogenic testicular mediastinum. These images that I'm bringing up on the right of the screen are from a teen who had XX gonadal dysgenesis, and this patient had ovotestes, and the testicular portion of the ovotestis was resected while the ovarian portion was left intact. And the ovarian tissue was preserved, and this functioned typical to a regular ovary. And this developed dominant follicles like this. And when we followed this patient up after seeing these dominant follicles, we could see that these resolved on a further examination with just small follicles within this. So the ovary part of this ovotestis, which was left, was functioning like an ovary. Not all ovotestis are identifiable. This patient had pathologically proven ovotestis that really had a non-specific appearance. I think we kind of suspected that maybe it was this structure here and this structure over here. And these were just described as non-specific gonads because people had a really hard time kind of even deciding for sure if this was a gonadal structure. And finally, we have streak gonads, which are very irregular hypoechoic structures that are made of fibrous material. These are all images of surgically proven streak gonads. If they are in the labioscrotal or the inguinal regions, like these upper two gonads, they can be much easier to identify and much more readily identifiable. If You're seeing this deep in the pelvis, like on these lower two images here, something like this, something like this. These can be misidentified as ovaries or testicles, but we don't really see anything that looks like a follicle. We don't really see anything that looks like a mediastinum, and these structures have a somewhat irregular shape, which could suggest the diagnosis. When you want to search for gonads too, you always want to consider about where the places are that you might be finding these. Testicles should be within labioscrotal structures, typically, but if they're not, you'll see them either in the high scrotum or the inguinal region most commonly. But in about 15% of patients with undescended testicles, you may have to look for an intra-abdominal testicle. The image that we see on the left is an intra-abdominal testicle that was identified near the inguinal ring right here. And the image on the right shows an intra-abdominal testicle identified adjacent to bowel loops. But in both of these cases, there's one thing that we can really hang our hat on to say that we're seeing the testicle, and that is that echogenic mediastinum that we see there, allowing for accurate identification. Finally, the last thing that you want to do is look at the retroperitoneum. Renal glands are going to be identified superiorly to the kidneys with this echogenic central medulla and this hypoechoic cortex. The thickness of these should be no greater than 4 millimeters, and the length should be no longer than 20 millimeters. And this contrasts with children with adrenal hyperplasia, congenital adrenal hyperplasia, and they will have these types of very large, thickened adrenal glands with undulating cerebriform appearance. Up here we see above the kidney, and that is abnormal, compatible with congenital adrenal hyperplasia. And it really leads into our final topic, which is kind of what we do with our most common STD or DSDs. Congenital adrenal hyperplasia is identified in the newborn period, and about 95% of the cases, these patients will have a 21 hydroxylase deficiency, and this leads to impaired production of glucocorticoids and mineral corticoids with excess androgens. We'll see XX infants who are going to have very masculinized external genitals. And these patients, if their karyotype is known, their physical appearance will be incongruous with what is expected based on the prenatal testing. Alternatively, these children may be assumed to be male but have non-palpable gonads that spur an imaging exam. Importantly, XY infants who have congenital adrenal hyperplasia will not have a phenotypic difference and may be identified on the newborn screen. In this XX patient with congenital adrenal hyperplasia, we see a uterus as midline with an echogenic endometrial stripe. This patient has no X chromosome, so testicles did not develop. This patient was not exposed to anti-Mullerian hormone, so they're not going to have regression of Mullerian structures. They're going to have development of normal Mullerian structures. Undulating adrenal glands are going to be seen in the suprarenal region bilaterally that have this kind of elongated and thickened appearance compatible with congenital adrenal hyperplasia. This patient did not have ovaries identified on their exam secondary to pelvic bowel gas. A second DSD that can be identified early in life is complete androgen insensitivity. But this is not going to be because of ambiguous genitalia. These patients will have a typical female phenotype that may conflict with a known Y chromosome from prenatal testing. Sagittal ultrasound of the pelvis will demonstrate no uterus, and testicles may be present. They will be either superficial or and adjacent to the inguinal ring or within the deeper pelvis. These testicles may demonstrate an increased risk of having a germ cell tumor at a later age. This is our testicle here. This is our testicle here. This one, I think we see the mediastinum on this image. We don't see it quite as well. And these will need to be surveyed sonographically, though, over time to make sure that there's not development of a tumor within them. So I just want to thank Jeannie Chow, Andrew Phelps, and Richard Yu, who helped with the paper that this was based off of and some of the images.